I've repositioned her because that's always our number one. Now what do I do? Yes, but I'm not just gonna put like a nasal cannula because Zoe's pulse ox is 99. She's a smoker, but she's holding up pretty good. So I'm gonna just flood her with 10 liters in a mask because what I'm doing is getting oxygen to the baby, not necessarily to Zoe directly. So I'm secondhand oxygen, right? Secondhand oxygenation, I'm just flooding her so she can perfuse. Because if I'm just giving a little bit, it's gonna take a lot of time to get there. Confused? Making sense? Okay, what about the veal chop? Makes sense?
Yeah.
Okay, what am I missing? Oh, okay, so my vagina in a box. It's exactly what it is. Okay, so when we go in to check a patient, you literally go in through the vagina and you're feeling for the baby's head and the cervical lining. And what I'm feeling inside is this. So this is probably, she's dilated to 5 or 6. The vagina does not dilate, just this. Our vagina stretches, sadly. So this is it. And that's why we tear, that's why we do all that, right? Because this is going to stay. So why would you typically, I didn't say this in the other class, I'm glad we're recording it. Why would you typically not tear as much on your 2nd, 3rd, 4th, 5th baby? It's already stretched. It's like a rubber band, right? Once you stretch it out, unfortunately, it'll go back. Not always the same. Good part is you have baby quicker. You don't tear as bad. First baby, also, you would think younger patients would tear more. They actually tear less because all the hormones and secretions, and they have all that extra going on for them. They're probably going to tear less, and they're going to have their baby quicker. So here's my head. Okay. I was telling them too, see these suture lines? That's how I can tell how my baby's facing. I'm finding their anterior and posterior fontanelles, suture lines. Now, what I was also telling them is a breech baby, a hiney crack can feel real similar to those suture lines. So if you don't know the baby's breech, it's not uncommon to be like, oh, I didn't realize I'm feeling hiney the whole time. So, because everything we do is not, it's by feel, it's not by sight. So we're feeling around, okay? I didn't tell this in the other class, and I always forget this is a good story. Hopefully Miss Scott doesn't mind that I tell this story every year because it's about her. Her oldest son, Jude, she would always say, because we were pregnant at the same time, and our boys are best friends, which is pretty cool, but she would be like, do you ever feel that just weird feeling like somebody's just scraping in your cervix, like something's moving? And I was like, no, it's my 2nd baby. But he came out like this. So she was just feeling his fingers all the time. So sure, yes. So when you go in to check her, you felt hand. I went in to check and had a baby grab my finger. That's terrifying. Because you're not expecting it. So you feel something grab you and you don't want to just be like, ah. So, but it is, it's terrifying. So ironically, that's why she kept saying, I feel that. Because I was like, I don't know what you're feeling. But it was his hand. And so he was just, his hand was here. So he came out like this. So there's all kinds of, interesting things. Yeah, like I said, hopefully she doesn't mind. I don't think she would be telling that story. I think it's really interesting. So your head, we hope, comes down, face down. And like I was telling them, when I say face down, I don't mean looking directly, vertically to the floor. I mean tilting down. And the reason is because our head, we can maneuver way better like this than we can like this. So when they're completely, we say sunny side up or face up, there's not a lot of give. And Brennan was saying how he saw them, twist them as they're coming out, totally normal. So you might do it like this and rotate, but if baby gets stuck in the pelvis, and so all I would see, it's hard because this would come through and you would only see the top of the head right here. You can't reach your hand in and turn that. All you would know is that the baby is stuck. So unless they're not contracting out, they might, not always, end up in a C-section. First babies face up are way more likely because you haven't had a baby before, so none of that is stretched. Okay, makes sense. Oops, sorry, makes sense so far? Okay, running out of oxygen in this mask. Whew. I need an oxygen tank. Okay, so we're talking about, let me see your cord. Okay, you can chill. I think I'm good. Okay, with you right now. Gosh, I'm all over the place. So this cord, right, we talked about how it kinks off. So what would happen if this baby had the cord ahead and started to come out of the cervix first? What would we need to do? What would happen? Critically thinking. Right, because it's going to, as it gets into the vagina, right, it's gonna get smaller. It's a prolapsed cord. Now, when I was in school, I told them, I pictured this in my head as it coming out the vagina. That's not typical. It's usually that it's come out of the cervix first. And what happens when I go to check my patient, instead of feeling this, I feel a rubber pulsation because I'm feeling the heartbeat. What would I need to do?
Were you just a baby?
What is it?
Were you just a baby?
Well, so actually I need to get this cord unkinked, right? So I'm going to push this back up, and then what am I gonna do? Because I'm gonna relieve pressure of the cord, and then what? Well, but see, here's the thing. This baby's already in Zoe's pelvis, it's engaged. That's what we would call it, okay? So even if I push it up, that baby can't go anywhere. I can't push the baby back up. So, Zoe, you're my pregnant girl. Her baby's coming out. I'm gonna push this back in, and my hand is going to stay there, relieving the pressure on the cord, while Zoe and I go back to the OR together, me on her bed, until the doctor does a C-section, takes that baby out. Because there's no good end to that. It can never come out first. Right, because we don't know that Zoe's baby doesn't get stuck. And so she's pushing and pushing, and her baby has big shoulders, we'll talk about that later, and it's called a shoulder dystocia, baby stuck. But what are we gonna do? This cord's hanging out. The baby's not getting anything. So I have to push this back up, and I have to wait, and literally waiting for the doctor to take the baby and the cord off of my hand. And then I can take my hand out. Okay, it is emergent. They were asking, like, what would I do? Who would I call? So I would ask the patient calmly to hit the button, and I would ask for another nurse to come in. And then I would say, I feel cord, quietly, and I would be holding pressure off. And she would say, okay. She would go call the doctor. Now sometimes, it's hard sometimes when you're feeling stuff, like a lot of times we'll say, can you check, do you feel cord? Like especially when I first started, you always second guess yourself. I feel like I'm feeling rubber and pulsation, but you don't want to call the doctor and say, there's a cord prolapse coming. You're not right. It's a little chubby arm sticking in the way. So we'll have another nurse, yeah, I definitely feel cord. And so then I'm gonna hold my hand in place. She's gonna call the doctor. We're gonna prep the OR, give her an antibiotic, all the things we would typically do that we'll talk about later more in depth, but for a C-section, because that's what we have to do. And we have so long to get the baby out. That's not in your book, and that would vary probably by hospital, but for us it's 30 minutes, like from touching to getting them out. We want it faster than that though. The downside of that can be, what if anesthesia is not there? What if we're waiting on the doctor? What if the doctor is at home, then they're speeding? We're looking at, we want it done in about 5 to 10 minutes. And that's typically how it happens. Because even if we have an anesthesia provider on call, we would call somebody else. It's emergent, you're not on call, we don't have anybody else to call. I was telling them there's a doctor, we have that, the baby's heart rate was down, and we couldn't get it back up. It was really slow, so she did the C-section as well as nothing. She just did it. Now, I think this patient was pretty safe as far as there was no history. I don't know that would have made a difference because then we're putting all of our lives on the line. But, so that's what we would do. So, cord prolapse, do you understand that the only end result is what?
C-section.
But what's our first priority? Relieve pressure on the cord. So, I'm guessing if you had an influx question, anything like that, those are going to be our priority questions. So, when you say relieve pressure on the cord, also realize too that there can be different ways to word that other than putting it back up in, like relieving pressure, things like that. All of that means the same thing. What am I forgetting?
I don't know.
Okay. Do y'all have any questions? I know that was a lot. Did the visualization